have with us tonight, Dr. Noel Brathwaite, who is from the Maryland Department of Health. And most of the time tonight will go to him, but for those of you who are new here, I do want to give a very brief overview of impact and where we are, and I'm going to talk fast. And if you would all mute, if you haven't muted yourselves, now would be the time to do so, and then we'll unmute you during the question and answer period, and we hope to leave plenty of time for that. So, first of all, just a very brief overview of the impact model. 100 women come together, donate $1,000 each as a membership fee, pool their resources to create a $100,000 transformational grant, which is awarded in one of 5 areas: arts and culture, education, family, health and wellness, and environment. Each woman has a voice in this volunteer organization, a voice and a vote. One woman, $1,000 contribution, 1 vote. This is a national model that has been in existence since 2001, and there are now over 50 chapters in the United States and beyond. Wendy Steele, who founded the first chapter in 2001 in Cincinnati, Ohio, is going to be a guest of ours next month on October 27th at our Zoom meeting in October. So I really hope you'll all put that on your calendars. She is a true visionary. She's a fascinating speaker. She's a good speaker, and it'll be worth tuning in for. So we are in Impact's founding year, and we have all these chapters across the country, and their leaders and best practices and all sorts of resources as we've developed our organization. But we are our own autonomous entity with a mission and vision that is directly tied to this community of ours. The impact model operates on a yearly cycle. So we're in the membership phase right now, and then we will move into accepting grant proposals, forming grant committees, which are all volunteer, reviewing grants, and then move to a vote at the annual meeting, and the whole cycle starts over again. So if you can go to the next screen, Lori, you can see that we are now in the membership recruitment phase. We are almost halfway to our goal, and we have 3 months to get there. We can do this. We are going to do this, and we need your help to get there. If you are not a member, please think of joining us. Founding members, we can use every bit of outreach help that you can provide. We're working very hard to create a diverse group that reflects all the corners and demographics of this community that we aim to serve. What are your responsibilities as a member? Well, you can contribute your $1,000 membership contribution and vote at the annual meeting. That is all that is required, and it's huge. It's a huge contribution right there. On the other hand, boy, do we need volunteers in this all-volunteer organization. So what could you do? For one thing, you could participate on a grant review committee. That is going to be the heart of our work next year. And participation is open to all members. You do not have to have grant-making experience. And the sign-up for those committees will be in early 2021. Do you have expertise in PR, marketing, communications? Join our member board strategic outreach task force. And it's a great way to get to know other members in a small working group. Some members of that committee are on the call tonight. It's been fascinating and has helped us out a lot. So consider that. And if you're interested in leadership opportunities, we have officer and chair positions on the board open. There's a statement of board interest on our website that you can fill out, or you are welcome just to contact me. And I'd love to talk to you about what's available. And if you wanted to help with tech assistance, database management, social media outreach, graphic design, contact me. I'm happy to talk to you. So the bottom line is just go to our website. We have a ton of information on our website, and so that would be the place to start. And then I believe Yes, so, and you can also find us on the following social media, and you can email us at president@impactdc.org, or membership. You can just memorize that at impact100dc.org. So we hope you'll contact. We love talking about impact, and we would love to talk to you. So I'd like just for a minute to put up our mission and vision because it's fully relevant to the topic of Dr. Brathwaite's remarks tonight. As you can see, our aim is to fuel the work of area nonprofits who are working for change by elevating their profiles and by providing them with the kinds of high impact grants that will allow them to implement significant change. And as you can see, significant change is the kind of change that we recognize is needed. The effort to improve the quality of life for all of us in this community means acknowledging the systemic and structural racial inequity that is at the root of so much need. Now, we know that we don't have the bandwidth as a small volunteer organization to solve these deeply entrenched problems that our whole country is trying to grapple with and come to terms with. But we can certainly offer our partnership and our support to those in institutions and organizations who have made this their life's work. Building bridges, establishing partnerships, developing a greater understanding of root causes of unmet needs in our community, supporting organizations that are working to implement viable solutions, that we can do. And it is work that is in the best interest of all of us. So without further ado, I'm going to turn this over to Vivian Aguayo, who is our chair of the Health and Wellness Focus Area Committee. She is the practice transformation coach with the Maryland Primary Care Office, and she will introduce our speaker. Vivian?
Thank you so much, Anne. And I would like to introduce to you all Dr. Noel Brathwaite. Dr. Brathwaite has been the director of the Office of Minority Health and Health Disparities since December 2017. He is an international public health expert who has worked on health issues in the United States, the Caribbean, and parts of West and East Africa. He has published a number of health-related articles in peer-reviewed journals. He is a graduate of Loma Linda University, earned a doctorate from the University of Maryland, and pursued postdoctoral studies at Johns Hopkins University, and also at the Center for Addiction and Mental Health, affiliated with the University of Toronto, Canada. Dr. Brathwaite's vision is to work collaboratively with Mental Health and Health Disparities team and other stakeholders to position the MHHD as a transformative and innovative agent that significantly lowers health disparities within the next decade. His goal is to advance prevention, equal healthcare access, quality treatment, and improved health for all populations in Maryland. I will add just a additional introductory note. I have only recently begun working with Dr. Brathwaite. He's been an excellent source of truth, working with the Program Management Office for the Maryland Primary Care Program, especially in the midst of a global pandemic. It just really solidifies the work that needs to be done in the face of such emergency and just really critical mass in terms of what is going on when it comes to health, healthcare, and what does it mean healthcare for all of us. Without further ado, please, Dr. Brathwaite.
And as Dr. Brathwaite, as we're switching screens here and he's putting up his slides, I just wanted to encourage you all to use the chat box to ask questions as we go along, either of Dr. Brathwaite or of us at Impact. And I will have plenty of time for questions at the end.
Good. Thank you, Anne, and thank you, Vivian, for your introduction. And you pronounced that I will be speaking the truth. That's what we intend to do this evening for the next 30 minutes. I also want to commend the organization Impact 100 DC. Can everyone hear me clearly?
Sure can.
Okay.
Yes.
I want to commend Impact 100 DC for its mission and vision and for using such big terms as significant change and root causes and also the viable solutions. Those are consistent with what I'm going to present this evening. It shows that significant change, which means that when we look at the before and after, we can certainly say that the after is significantly different from the before. It means, therefore, that as a result of my presentation this evening, that Impact 100 is going to be significantly different, and that the community that it serves is also going to be significantly different as a result of some of the things. I'm hoping that my slide will be able to advance so that I can continue with my presentation. And I'm still seeing that I'm stuck
Push
on
the right arrow, right, Vivian?
I-
There we go.
that. Okay.
There we go. Okay.
Now, one of the instructions that I was given was that I should focus on the region. Those of you who are from this region, lift your hand in the air. You know, the region that you have, DC and Northern Virginia and Maryland, is a very rich region. If one were to describe the region, we can say that the region of Maryland and Virginia and also the district is one that is desirable on the one hand. And on the other hand, we find that in the midst of the wealth of this region, there are groups of people who are not as fortunate as the other groups, and they're being left behind. And the map that you see here in the darker blue, gives you an indication of the wealth of the region. I don't know what happened just now. We have here the...
Just upper right-hand corner, X.
We have here the specific, okay. Thank you, it's always good to have Vivian to help me. Okay, so the dark blue will tell us where the wealth is. And as you go to the lighter blue, we find that you are less wealthy. So if we were to describe the region that we live in, it's a region where a number of persons are excluded. And that is of big concern to Impact 100. It's also a big concern to the Office of Minority Health, because we cover the state of Maryland. And we know that there's wealth in Maryland, and there's also poverty. That there are opportunities in Maryland and Washington, DC, and Virginia, and there are also unequal opportunities. And so in the midst of the wealth of the region, is what we consider to be wealth mixed with poverty. And there are some census tracts that you have high levels of what we consider to be life expectancy. And then we also have lower levels of life expectancy. And then it poses the question, what is the difference between the rich communities and the poor communities? Is it just a matter of life expectancy, or is it driven by something that can be prevented and something that can be rectified? It is what we call the social determinants of health. The determinants of wealth and the determinants of poverty. They are determinants of health, and they are also determinants of ill health. It all depends on how these determinants are structured. And some of the determinants are housing, transportation, even wealth and education. And so these combined give us the differences that we see. So uneven opportunities in the midst of wealth is responsible for what we consider to be ill health. And overall, findings show that health in the metropolitan Washington area is often not shaped by the healthcare system, but is shaped by what we consider to be the determinants: income, education, housing, transportation, and the environment. And then when we look at the other picture, we find that we have the rich neighborhood and the poor neighborhood, the healthy and the unhealthy, the social determinants of health, and that people of color and immigrants were more likely to live in neighborhoods with fewer resources. And as a result, we find that that is a contributing factor for ill health. Has this been something that is new? No. There's a statement here which I would read. It says, for generations, African Americans have experienced higher mortality rates than whites. And notice they said for generations. And in my presentations, I'm going to take you back to some of those distant generations. And so African Americans have experienced higher mortality rate. I mentioned life expectancy a while ago, and now we come to another differential, which is mortality rate. It says that for generations, the mortality rates among whites and Hispanic and African Americans have been different. That is, the Hispanics and the African Americans have died at higher rates from diabetes and other chronic diseases. And so such inequities help explain why life expectancy can vary by 28 years across the metropolitan Washington Council of Governments region. And that's a direct quote. And one of the measures of that difference is what we consider to be the population representation. So on the one hand, African Americans account for 93% of the population in the 5 census tracts with the lowest life expectancy, but only 7% of the population where life expectancy is highest. So if you look at life expectancy by race and proportionality of race, we find that in the lowest life expectancy, we have the highest percent of African Americans living. And the highest, we have the least amount of African Americans. And those of you who travel on the red line or the blue line or the yellow line, as I do sometimes, on the orange line, we find that there are these disparities. We are talking about the region that we live in. And the region is dotted by these lines of transportation. And the region, when you look at the lines of transportation, there's also large disparities. So that when you go from the start of one line, for example, in Washington, D.C., to Silver Spring, you will find that the line differential is not only different relative to color, but is also different relative to life expectancy. So we do find that between Washington, D.C. and certain parts of Virginia, when you travel on the red or orange lines or yellow lines, you will find that traveling along those lines would also give you bring you face to face with the differences in life expectancy. What has happened is that disparities in today's communities were shaped by decades of exclusionary practices. And this is a truth that Vivian said that we would hear. The truth is that disparities in today's communities were shaped by decades of exclusionary practices, and that non-white families were prevented from acquiring property and transferring generational wealth, reducing revenues for schools, neighborhood infrastructure, economic developments, and so on. That is the picture that we are going to discuss, because it brings us to ask the question, Since that is the picture, tell me, what do you mean by health disparities? And this is a quotation from CDC, which today is going through some rough times. But the CDC, when this particular description was made of health disparities, no one questioned whether it was a truism or not. That was the truth. And it's still the truth relative to the description of health disparities. So that is the description of health disparities. Now we come to causes of health disparities, because not only do we want to know that there's a difference in life expectancy between Black and white, and there's a difference between mortality, death between Black and white, and the differences can be traced along the various lines of transportation in between DC and the suburbs, DC and Montgomery County, DC and Prince George's County. We find that there are other factors that contribute to these disparities, where you have premature death among Blacks, premature death among Hispanics. And the situation is that these kinds of statistics cause us to ask the question, what are the factors that are driving these disparities, the differences in health outcomes? We have a list of them, including systemic, social, or structural racism. Poverty is another one. Inadequate access to health care. And you know that there are communities where there are no hospitals, and there are communities where there are multiple hospitals. And that is what we consider to be inadequate access to health care. We also have individual, we can't always blame everything on systemic racism and structural and poverty, but also individual or behavioral factors like dietary habits and exercise. For example, I don't live too far from the park. And when you go to the park to see exercise, you see there's a differential in the race and ethnicity relative to exercise. So that's an individual behavior factor. Some individuals can say that security is a big factor in non-exercise, where you might be afraid to go out in your neighborhood and walk or run. Those are things which occur, and those are the realities, but there are individual and behavioral factors that contribute to health disparities, and educational inequalities also contribute to these disparities. So we have the term disparities, and now we come to another term which has to be used in the context of this presentation this evening. Once again, we call on CDC to give us a definition of health equity. And CDC says that health equity is achieved when every person has the opportunity, and that's the critical term, opportunity. We find that the difference sometimes between the wealth as measured by one measurement of wealth is the kind of house that you live in. Some people live in $1 million house, and that's considered to be wealth. Another person might live in an apartment which is considered non-wealth, or live in a house of $100,000. So we find that that's something, the wealth is something that could be based on structural lack of opportunities or education lack of opportunities. So whenever we talk about wealth distribution and we talk about disparities and equity, we come to what we consider to be an opportunity. Not opportunity not only to get wealth, but an opportunity to be healthy. And when a person is denied the opportunity to be healthy, then that is what we call an inequitable situation. And so there are some markers of equity, and there are the differences in length of lifespan between groups, the differences in the quality of life, the rates and severity of diseases exhibited in a group, disabilities and treatment of affected individuals. So when you look at one group versus another group and compare the outcomes, then we can say that there's disparity and there's also inequity. One of the things that is taking place in the US today is what we call the race dimension. And American race and ethnicity play a big factor in explaining what is taking place. And we all hate on the news, we all read it in the newspaper, and we see it on television, the struggle that is taking place currently. And so that is the big thing that is playing up in the differential between outcomes of health and outcomes of wealth, where we have disproportionality and equal impact in health outcomes. Differences in access to appropriate medical care could be based on one's race. But as I mentioned earlier, this is nothing new. If you go through the history of the United States and healthcare and race relationship, you find that as far back as 1895, Booker T. Washington and William B. Du Bois, they talk about the health of post-slavery blacks was poor. And that was in 1895. Slavery ended in 1865. So 30 years after the end of slavery, they considered that the health of the post-slavery blacks was poor. If we come to 2020 and ask the same question, what is the health of the Black and Hispanic population? Generally speaking, we can also conclude that the health of this race is poor. The other indicators that would take place in 1895, we come to 1915. And once again, 20 years after 1895, and you ask the same question, the death rates were 20.2 per 1,000 for blacks as compared to 12.9 for whites. And that is indeed a disparity. Infant mortality in 1915 for blacks, 180.6 per 1,000 live birth, compared to whites, 98.6. Now, that's 1915. Let's go to 1965. 1965, we aren't going to show you the data, but we're showing you things that would impact the health of the health of blacks and also the data that we see. It says that in 1965, there was a transformation, just like we had in the statement that was done by Anne Vaughan. She said that transformation, significant change. So there was a watershed moment in 1965 when we felt that there was going now to be a time following 1965 when the health of African Americans and Hispanics would improve. That was because we had Medicare and Medicaid, and we also had the civil rights movement taking place and great gains. But by 1985, 20 years after the 1965 passage of those regulations, there was a report considered to be a watershed report, Heckler Malone, and they documented the continuing existence of health disparities. Remember, you saw the data from the timeline 1895. 1985, the continuing, not the elimination of health disparities, but the continuing existence of health disparities. And in 2002, we also had some mention of the IOM report confronting racial and ethnic disparities in healthcare. And the major finding of that 2002 study was that race and ethnicity remain as significant predictors of healthcare quality. So we have between 1895 and 2002, some similarities taking place. Now, back to our region. And in 2020, the Washington, D.C. Regional Health Profile. It says here that the healthiest places in metropolitan Washington are in the northwest wards of D.C., the affluent suburbs of Maryland, and most of Fairfax County. So those of you who happen to live in these jurisdictions, those are the healthiest places in this area. Now, the dichotomy, the least healthy places, as I mentioned, that in the midst of wealth, there's poverty, in the midst of health, there's unhealth. So the least healthy places are in the eastern wards of DC, in Frederick County, in Frederick City, Southern Charles County, and Southwest Prince George's County. One of the things that they have noticed is that there's a clear east-west divide in DC when it comes to health opportunities. A great divide between the east-west. And then when you come to Montgomery County, we can say there's a great divide between Silver Spring and also the other wealthy parts of Montgomery County. And if we look at Prince George's County, we can say that there's a great divide between the wealthy parts of Prince George's County and poor sections like Hyattsville and so on. So just like in DC, when you look at Virginia, the same thing that is taking place. In one census tract, you can have the household income of 244,000. In another census tract nearby, we have people living in poverty. Indicated there's a stark contrast in conditions for health and opportunities across the county. For example, Bethesda, a majority white population in some census tract, at least 97% of adults attended college. And the unemployment rate is less than 1%. 8 miles away from Bethesda, Langley Park, and other areas that have large population of immigrants and racial minority, the picture is different. For those of you who are interested in more data, I have listed data. I'll go through that. Infant mortality data, heart disease data, cancer data, diabetes data. And what do all of these say? All of these unhealthy weight data, all of these indicate that there's a difference between the health outcomes of whites and the health outcomes of people who look like me. But in the midst of this inequality, we have now another situation that has what commentators say has exacerbated the condition. So we can cite lifespan, we can cite the other diseases, the diabetes, we can cite unhealthy weight, we can cite the rich counties and the poor counties, the rich sections of counties and the poor sections of counties, and we could deal with all of the other lack of opportunities. But then in the midst of all of that, there's what we call now the coronavirus. Coronavirus has, as some commentators have said, have shown up the racial inequities as never before. It has indicated that minorities are more vulnerable to the virus than possibly other conditions that they are prone to show differences in. One has described the coronavirus as a traveling infection. A traveling infection, it goes from place to place and has upended the lives of vulnerable populations here and worldwide. And COVID-19, as never before, is exposing those underlying conditions. It means that the conditions that existed from 1895 and even possibly sometime during slavery, but they were highlighted in 1895, and this is 2020. Between 1895 and 2020, you have waves and waves of inequities and waves of disparity. So what COVID-19 is really exposing is the underlying health disparities, so that racism in and of itself has now become a public health issue. When we look at the health crisis of COVID-19, I wouldn't go through all of this, but it just because you're quite familiar with the data, and it's indicated that in the United States, we have over 200,000 people who have died. And the data indicate that of those, 53% are minorities. But we don't have 53% minorities in the United States living. So that is what we call the disparity, where the disproportionality population-wise with the outcome. So that if we have a situation where you have 13% Blacks living in America, and the death rate is 40%. That is a clear disparity. How could 13% of the population contribute to 40% of deaths? And how could, in the terms of Hispanics, 18% Hispanics in the United States contributing to 30% of deaths? So we find that those are data points that we have to consider. And because of COVID, it said Blacks are at greater risk compared to whites. And that's always the reference comparison, Blacks and whites and Hispanics. 2.6 times higher cases, 4.7 times higher hospitalizations, and twice the amount of deaths. And that's according to CDC. And there we have some more data points that we're highlighting. We have the effect of gender, which means that men are more likely than women to die. We have another impact in terms of jobs, where there are disproportionately more jobs lost by minorities than jobs that are lost by whites. As I said, that we are speaking what Vivian said was the truth. So I'm just telling you the truth of what is taking place. I'm the messenger of data. It says that by early April 2020, nearly 40% of households with income below 40,000 were laid off or furloughed. What happened to those with income of over $100,000? And it said that the loss of insurance is also felt more by those who can least afford to be uninsured. There you have some other data about the impact of the coronavirus. And there we have some other statements that I alluded to, that Blacks are less likely than whites to have access to health care or health insurance. And more often, Blacks and Hispanics and minorities more often live and work in crowded conditions where social distances is not possible, and where most essential workers who are unable to work from home are considered minorities. So that is the dilemma. There's a conundrum whereby one group of individuals are not as fortunate to have the same opportunities as another group. And this has displayed itself in the kind of health outcomes, death and sickness, and economic outcomes, unemployment, and so on, the social determinants of health. So little wonder then that when we look at the attitudes of those who are dispossessed, we said that Blacks are less trusting of the healthcare system than Hispanic or white groups, because we know that at one time, because of the Tuskegee experiment and because of the time when Black doctors could not become members of the American Medical Association, they had to establish their own medical group called the National Medical Association. There was a time when Blacks could not go to the same hospital as whites, and if they went to the same hospital as whites, they had to be in a Black ward, and where some nurses could not treat Black patients. And those were situations existing in the healthcare system and situations existing in the Jim Crow era. And so when we look at the clinical trials now, and we want Blacks and minorities to be participants of the clinical trial, because for clinical trials to be effective, to have a vaccine that is effective, they must have representation from all ethnic groups and racial groups. But this is not the case currently. And Blacks will probably be less willing to trust or take a new developed vaccine to COVID-19, which places them in further unhealthy conditions. As a matter of fact, it is said that Black doctors now are wanting to ensure that the vaccine developed by possibly the absence of fewer Blacks than is necessary, that they want to make sure it is one that is safe and effective. We go on to, this is what we do. We follow the data. We try to use our office and that's the mission and vision. We try to use our office to highlight not only the data and the differences in terms of health disparities, health equity, but we are committed to the task of bending the arc towards justice and health. That's our commitment. You can have access to the slides later to show you some more of what we do. We fund motor grantees in jurisdictions across Maryland. We fund socioeconomic packages for those who are impacted by COVID. We fund studies by HBCUs in terms of knowledge and attitude. We have a breastfeeding program. These are some not related to the COVID, because we go before COVID, what we did, during COVID, what we're doing, and beyond COVID is what we'll continue to do. So the question that naturally asked is, you have highlighted the problem, you have highlighted the disparities, you have highlighted the inequities. Now, what is the solution? I'm going to spend a couple of minutes dealing with what should organizations like Impact 100 DC be doing? What should they be doing? I refer again contextually, which will give you a context for the work that you would like to do or you have been doing. It says that the irony of the Washington region, because that's your location of work. The irony of the Washington region is that there is a considerable amount of wealth and opportunity available to residents. But those opportunities, as was shown earlier in the slides, those opportunities are unevenly spread, very often at no fault of the individual. That is the context, the analysis, situational analysis that Impact finds itself in. Considerable wealth, unequal opportunities. So they're called the islands of disadvantage in Northern Virginia and the segregated areas of Southeast DC and Prince George's County are reflective of a past that has contributed to generational, multi-generational poverty. And that's according to the Washington Council of Government. And this has induced conditions that adversely impact residents' health by limiting access to social determinants that help people be more healthy. So we have set now the framework for action. What can an organization like Impact do in collaboration, I should say in collaboration with the Office of Minority Health? I think that we went through the mission and vision of your organization just now. We also heard about the resources. $1,000 for 100 persons would give you $100,000. That's a resource that you would have available to help with. And also your capability in terms of the skill and competencies of your 100 members. I know right now you only have 46, but you want to grow. And I don't know if you are open to having males in your organization, but you know.
Friends.
friends of 100. Okay, consider me a friend. So you have your mission, you have your resources, potential up to 100,000. You have the capability of up to 100 members. So you're in a good place. Impact 100 is in a good place. It means then that one of the things that I encourage Impact 100 to do is to monitor, track, evaluate, and sustain programs. And notice the term investment, because when you give your grants, that is an investment to an organization that says we're going to carry out the mission and vision of Impact 100 because of dedication to disparities elimination and dedication to achieving equity, so that the opportunities that are absent can be present in a large segment of the population. Another thing that can be done is to motivate members to take a personal interest in finding everyday solutions. And sometimes the solutions have to come from within, in discussion with members of the community. And one of the things that I always tell when I do some university lecturing and also some webinars is that we have to listen to the voices of the people. And I'm sure that that's one of the dictums that is very important. We should listen to the voices of the people and spend time listening and conducting those needs assessment prior to offering solution. So we need a lot of participation by the members of this organization to make a difference. So moving forward, I would think that over the next 3 years, we have the phrase again, significant change, root causes, viable solutions, as was said by the president. As noted in the report that I alluded to, and I quoted from, doctors cannot solve the socio-economic challenges or improve neighborhood conditions, and I would say by themselves. Doctors can be, but the solution to the socio-economic divide rests not just with the healthcare system. The solution to disparities and the solution to inequities lie in what we call attacking the social determinants of health. So moving forward, this region of ours, must work to improve economic and social conditions for populations in need. Moving forward, we must work to straighten out the public health system. And moving forward, we must invest more in communities and ensure access to quality healthcare service in every neighborhood, not only the rich neighborhood, but in every neighborhood. I hope, therefore, that as I have brought my discussion and dialogue with you to an end, that the message will remain with you. Move forward, work together to improve the economic and social conditions for populations in need, and then within 3 years, you will see significant change in this region that we call home. Thank you very much.
Dr. Brathwaite, thank you so much. Boy, that's a lot to take in, and fortunately, and we have a recording which I will go back and listen to and watch again. Way too much to take in at one time. We thank you very much. We have one question in the chat box, so I'll start with that. This is from Alice Goodman, who talks not only of access to quality, access to healthcare, but quality of healthcare, and talks about her experience with Medicaid, which is horrible. And she asks, do you have any specific suggestions for everyday solutions for our group?
Everyday solutions, but you have a health, I'm sure you have your plan of action, but it's a 1-year plan or 3-year plan of action, and that plan of action is broken down by objectives, and those objectives are then broken down by certain actions. So for every day, one can always adopt a particular census tract or a particular zip code or a particular neighborhood, because they're people, you're dealing with people. And if you can adopt a family or 2 families, if you belong to a church group, you could do the church group or community-based organization. So day by day, you set your goal for what you are going to achieve with people for that day. It could mean a phone call. It could mean just meeting on a WhatsApp chat, because people are social agents and they need someone to say hi to. So even a phone call to someone not of your organization would help. So day by day, you can ask the question, what am I going to do today to help alleviate disparities and also achieve equity? Reach out by a phone call, reach out by a WhatsApp, reach out by sharing some individuals who live in food deserts. Possibly you might be able to take some food to them. Some people might live in a situation where they could be facing eviction because COVID-19, helping individuals with rent, helping individuals with utilities. Those are some things that we are doing as an organization to help individuals. Those who don't have insurance, you can help them connect to insurance through the expanded. And I think October is a time for enrolling in Medicaid. So there are a lot of things that you can do. You can keep a journal with all of the things that you can do. And when you have your meetings, you can collectively discuss what you have done.
We have a comment from Andy B, who says, hi, as an example, I'm in LA. We have people who provide masks to others, make sure seniors get meals.
Yes, good advice.
I will just mention, because health insurance was mentioned, the Maryland Health Connection has extended the emergency enrollment period. So if anyone knows anyone that needs health insurance in Maryland, you can sign up through marylandhealthconnection.gov through December 15th. So it's open right now. If there's anyone that's uncovered, please point them in that direction.
And remember also that there's a lot of stress, anxiety, and fear. If you give your friend a call, that could make the difference in their day, how they spend their day. So in addition to the mask and the washing of hands and social distancing, individuals are undergoing a lot of stress, a lot of anxiety, a lot of depression. A phone call, a card could make a difference in how they spend their day. So give a friend a call. That could help them to really be less stressed.
Julia asks, if a health organization is interested in receiving a grant from Impact 100 in the future, are there key questions we might want to remember to ask them regarding their role in addressing health inequity? That's a great question. Sharon, do you want to speak to that?
Okay. It was actually also Dr. Brathwaite, if he has any suggestions.
Oh, okay.
For grants?
That might be better.
Oh, if you are a community-based organization in Maryland, certainly you can, because we are funding right now. We are funding HBCUs to do 4 HBCUs. We are funding to do studies in Washington, and sorry, not in Washington, but in Baltimore City, in Prince George's County, in Baltimore County, about the knowledge, attitude, and so on. So we're funding them. We're also funding 5 of the largest health departments to provide packages up to $1 million to individuals who need social care. We're also funding 21 community-based organizations to provide education about underlying conditions, diabetes, hypertension, cancer, obesity. And we're also funding an organization to do breastfeeding. So if you need some information about what we do, just give us a call.
So Dr. Brathwaite, if you could, a question is, what questions would we ask who apply for a grant? What key questions to ask them about their role in addressing inequity?
Oh, okay. How do you write a grant to be successful?
Well, and how do we assess the viability of a proposal in terms of addressing root causes rather than just symptoms?
Okay. There are 2 questions on the table. Seem to be one thing about how to get the money, and the other one is how to get the evaluation. The key question for health equity is dependent on the issue because health equity is not just a concept. Health equity is rooted in what is the experience of the population. If the experience of the population that you are targeting is housing, the question that the grant evaluator is going to assess is, how do you plan to assist with the housing need because you have identified that the health inequity is housing. And the question of helping housing could be one with the rent, with utilities, or if they're facing eviction, with some mechanism by which they can move out. So one of the questions is, how successfully are you going to bring about a change of the situation that you want to address? If there's housing, can you pinpoint what you're going to do about the housing in the next year, given if we give you $50,000, can you do what you say that needs to be done based on the data that you collected to indicate that the problem? How closely can you solve the problem? So for the reviewer will ask the question, how closely have they addressed the issue that they have highlighted that need to be addressed? So there's a need. Can I meet the need? If you can convince me that what you have written helps me 95% to meet the need, then I will give you the grant, because you have scored high enough in addressing the problem that you have collected data. Say, well, this is the problem. This is the solution that I'm going to guarantee that 95% chance that if you give me the money, I'm going to solve the problem. And you say, well, I review your grant, and you have indicated that the strategies, the initiatives that you have highlighted are going to solve the problem, then I will give you the funding. So it has to, the score has to be at least in the high 90s, as against personally someone who has scored low. I hope I've answered the question.
Okay. Yeah, thank you.
If I haven't answered the question, give me a call, 410-299-10.
Oh, that's risky.
And I would spend some time going through the question, but there's a fit between the problem and the solution. If you can really address the solution, then within a given time frame, the reviewer will say, yes, I would give you a high score and you get the grant.
Well, Dr. Brathwaite, I'm conscious of our time here. You did a remarkable job rolling through a huge amount of information, and we certainly appreciate your time here with us tonight. And would love to have you come back again, and are delighted to have you as a friend.
I thought you told me I'm an honorable member.
Yeah.
Honorary member. But we would like to work with you. Certainly, we would like to work with you as best as we can to help address, because we can't keep individuals in poverty, lack of housing, and food deserts and bad transportation. We can't keep them suppressed as much as they have been. We should be seen now as liberators, as people who are taking individuals out of poverty, out of the distresses that they have been placed on them by the system. And I'm going to speak clearly, as Vivian asked me to do. We must do our part, even if it's just one family that we help during this COVID-19. You would have done your part. Thank you very much.
Thank you all, and feel free. I know some of you have to leave. Someone is asked to say something.
Hi, Dr. Brathwaite. My name is Elvan, and first, thank you for being here, of course. And I recently watched the panel you were in on Zoom, and the panelist was asking a question to everyone, that what is the one word to describe how you are feeling today in the midst of the pandemic? And many participants mentioned the words anger, overwhelmed, frustration, of course, rightfully so, but your word was optimistic. And I love this answer because it involved energy and passion for change. And with everything going on in the world and in our own lives, it's so hard to have an optimistic perspective when our bodies and minds are holding so much tension. Yet, the optimism, as you said, is the Kickstarter to move forward from feelings of being out of control and beyond help into accepting reality. And this is where we are now. And how can I contribute to what needs to be changed in the system? And I think that individual responsibility is power, because I saw something about everyday solutions. So I think we can start from there, that individual responsibility in any way we can help. It doesn't always have to be monetary. I personally teach at mindfulness and relaxation practices at behavioral health hospitals. And I see the most patients admitted there are from Black and Brown communities. And many of them are coming from really low income households. So I see their life conditions and what they need. And in my humble experience, just to 10 sentences, I try to teach them the ways to ease tension in their hearts. And so I just wanted to mention that I think mental health, especially in Black and Brown communities, is already a neglected area. And so there must be funding for programs to address trauma and build resilience, so they can internalize the primary benefits of self-care, because health care starts with self-care. Thank you.
I'm saying amen to that. But
Thank you so much.
Here, here.
All right. Well, we have a big political night coming up here, so I think everyone should go get prepared. And thank you again, Dr. Brathwaite, for being here with us. Thanks to all of you who came, members and guests, and nice to see all of your faces. And please tune in next month as well. We'll be sending reminders.
thank you very much.
Okay, thanks so much.
Thank you, everyone. Good night.
Lori had to leave us. All right, you all.
So I think that was very nice. Ellen, did you say something? You're on mute, I think. I'm still a little stunned.
I said fantastic.
Yeah.
Excellent. Really, really excellent. I mean,